Hi, and welcome back. Before I jump into today's video, I wanted to thank PJ. PJ Dreams recently gave me a shout out on his channel. And for someone like me with a channel in its infancy, that's pretty cool. PJ is a giant in this space, and he has been for a number of years. And if you're at my channel and you don't know who he is, well, first of all, I'm not sure how that happened, but I will link his channel down below so you can check him out if you haven't seen him. I noticed it when I got some comments on some videos that said, PJ sent me here. It's a very humbling thing to be noticed by somebody like that in this particular space, and I certainly don't take it lightly. Otherwise, you'll notice my background is different. It's different now than it was in my previous video, which was different than the previous video still. Well, a lot of crazy things have been happening in my life recently. I moved out of my apartment. I moved into my friend's basement for a month. And now I am in my home. And for the first time in my life, I have an office, which I will hopefully morph into a studio and, based on the back of me, maybe get some furniture. But first, change this color. I don't like this color. But for you guys and the shout I got from PJ really makes me think I'm onto something here. So I will continue with this behavior, and content has been sparse lately. But given that now I have a place to record, we're coming back strong. So what's more, I will say, is my medical board exam is coming up pretty quickly. I am getting nervous, so over the course of the next month or two, get ready to learn a lot of medicine. Tonight, I'm going to do a cardiology section with you. I was thinking about this earlier, why I do a lot of cardiology stuff. And there are two reasons, I think. One, because it's really what I enjoy the most. But two, it strikes me as people are going to get the least queasy with cardiology things. But maybe that's my own biases at work. But thank you to PJ. Thank you to all of you for encouraging this behavior. Let's get started. I want to let you know that these are all not real patients, and I will be changing some of the not so pertinent things in these questions, because copyright is still a thing. I don't want to get in trouble. So let's jump in. 57-year-old guy. He's got right leg pain, thigh pain. Gets really tired when he walks. Doesn't have any chest pain. He hasn't passed out. No abdominal pain. He has erectile dysfunction that he developed over the past year. His patient's other medical problems include a lot of them. He's got kidney disease. He's got high blood pressure. He's got high cholesterol. He's got gout. He's got reflux. And he has smoked 2 packs a day for the past 20 years. And he still smokes. That's a lot. His blood pressure is a little bit high. He's a little bit overweight, but not terribly so. He has a bruit over the right carotid artery. A bruit is something we can hear. He's got good pulses. There's a small ulcer at the tip of his right big toe. Ankle brachial index is 1.0, which is normal. His serum creatinine, indirect measure of kidney function, is 1.6. It's a little high, but we knew that from his past medical history. His hemoglobin A1C is 7.5. It's high. The question asks, which of the following is the most appropriate next step in the management of his leg pain? We could give him aspirin and cilostazol. We could do a CT scan of his legs. We could do exercise testing with the ABI, ankle brachial index. We could do more aggressive glycemic control, or we could treat his diabetic neuropathy that he may or may not have. So let's think about this. His ABI is normal, but that may be just at rest. So what else we got? Well, we're not convinced that he's got peripheral arterial disease, although we kind of are, but we don't have enough evidence just yet, I don't think. So I'm not sure that we should do aspirin and cilostazol. Besides, the first thing would be to do an exercise routine. Should we CT his legs? I'm not sure why we would. Do we treat diabetic neuropathy? No, I'm not sure he's got diabetic neuropathy. Do we more aggressively control his blood sugar? I mean, we're going to do that, but that's not what he's asking. They're asking for his leg pain. I think we have to do an exercise stress test with a repeat ABI. No, it doesn't say exercise stress test, it just says exercise test. It's cardiology section, so I'm used to stress test. Before I click the submit button, I'll explain why I think that's the right answer. Because he gets the issues while he's walking. So he may have just enough patency or opening in his blood vessels in his right leg to be okay when he's just sitting there. But when he's up and walking around, maybe there's not quite enough, because when you're up and walking around, you need more blood. And maybe his veins and arteries aren't quite open enough. Let's see how I did. I was correct. It looks like I was correct for the correct reasons, which is probably more important. Alright, next up we got a 66-year-old guy. He's got high blood pressure and was diagnosed with high blood pressure a couple years ago. He's been following a low-salt diet, trying to lose weight. But last time he came to clinic about 7 weeks ago, his blood pressure was 176/95. Very high. His medical history is notable for gout, and he's had 2 episodes of gout over the last year. He was on allopurinol and then taken off because of side effects. Doesn't smoke, drinks a little bit but not a lot. Blood pressure and click, 174/101. Jeez. He is a little bit overweight, but not terribly so. Labs of note, his LDL is a little high at 100. What should we give this guy for meds? Well, all he's got is gout. But his blood pressure is very, very high. It's asking me what I want to give for meds. So, one answer is atenolol, which is a beta blocker. Another one is hydrochlorothiazide, which is a diuretic. The other one is hydrochlorothiazide and metoprolol. Metoprolol is a different beta blocker. Another one is losartan and amlodipine. Losartan is an ACE inhibitor, and amlodipine is calcium channel blocker. I think I should look that up to make sure. I'm sorry, losartan is a angiotensin receptor blocker. Works the same pathway, just the next step. And then the last one is metoprolol and lisinopril. Well, let's look at his vital signs. Blood pressure is very high. Pulse is, let's call it 80. His creatinine's fine, his hemoglobin's fine, his potassium's fine, his hemoglobin A1C is also fine. That's important to note. Essentially, how do you want to start him? I think they're asking me about his gout. Well, let's see. Yeah, they were getting a little fancy. Effectively, they wanted me to not give him hydrochlorothiazide. Because what can happen is hydrochlorothiazide can make the uric acid in the blood go up. What they want is what will decrease the risk of a gout flare. And losartan and amlodipine was correct. Now, we can go through this answer a different way. We can do it like I did. First of all, atenolol for monotherapy. Not going to do the trick. Hydrochlorothiazide, like I said, we don't want to do that for this guy. So, hydrochlorothiazide and metoprolol. We're times 2, no thank you. And then if you go down to metoprolol and lisinopril, not a terrible idea. If his heart rate was going fast, I would think about it. But losartan has been shown to decrease the risk of a gout flare, and a calcium channel blocker has also been shown to decrease the risk of a gout flare. What's more, metoprolol is a notoriously weak antihypertensive medicine, so it won't really lower your blood pressure that much. Metoprolol is a great drug, don't get me wrong, but there's a time and a place. So losartan and amlodipine. Cool. Moving on. 65-year-old guy is in the hospital. He had a heart attack 3 days ago. Now he's got chest pain. Hurts worse when he takes a very deep breath and radiates up to his neck. He had a cath 3 days ago. Distal left anterior descending artery occlusion that could not be revascularized. It's pretty far down there. Then he was treated with aspirin, Plavix, atorvastatin, metoprolol, valsartan, all good drugs. He has a friction rub on physical exam. They did an echocardiogram. It shows apical hypokinesis, which makes sense. The apex of the heart is at the bottom. And the occlusion is very, very far down there. So it would make sense that the bottom of his heart's not really moving that well. His ejection fraction is fine. There's a little bit of a pericardial effusion. So, what do you want to do for this guy? Do you stop the aspirin and Plavix? Do you put the aspirin at a higher dose? Do you give him heparin to anticoagulate him? Do you give him ibuprofen? Or do you give him low-dose prednisone? Well, first, we gotta see what he's got. So what has he got? He's got pericarditis. He's got, more accurately, peri-infarction pericarditis. Which is kind of peculiar. I'm not sure how you treat this. So learning is going to happen here. If not for you, then for me. So, ideally I'd give him colchicine, but maybe you don't. Okay, let's do this way. You don't stop the aspirin and Plavix. You just, no. Maybe you give him more aspirin. I'm not sure. You don't give him heparin because you're not anticoagulating anything. Maybe you give him ibuprofen. I don't think you need to give him steroids. I'm going to guess go with aspirin. Nice. But why? Let's see. Oh, it usually just goes away on its own. Okay. Interesting. This says it usually goes away on its own, but if a patient has symptoms, just give the patient higher doses of aspirin. And then it lists all the other meds that were options and says don't give those. Helpful. Alright, what is next? I got a 6-year-old guy. He's got chest pain when he's in bed at night. He's got real bad coronary disease. He was diagnosed a year ago. He was offered bypass surgery, but he said no thank you and wanted to be treated with pills. Since medical therapy started, patient's symptoms have improved, and now he's got chest pain during the day only, but after moderate to severe exertion. But he still wakes up about half the time overnight with chest pain. That usually goes away on its own, but sometimes it needs a nitro tap. Yikes. He's got bad high blood pressure. He's got high cholesterol. He's got peripheral vascular disease. He smoked cigarettes for 35 years, but quit 5 years ago. He takes aspirin, metoprolol, isosorbide mononitrate, amlodipine, lisinopril, rosuvastatin, and nitroglycerin as needed. All good drugs for this guy. He takes all of his meds in the morning. His blood pressure is high, 150/82. His pulse is fine. Respirations are fine. It says the patient is obese with a large neck circumference and a BMI of 34. Clear chest, no swelling. Everything else is normal. Gets an EKG done. Sinus rhythm. The most recent echo had a good ejection fraction. Heart squeezing nicely. He had a moderately extensive inferior wall reversible defect the last time he had a stress test. So what do you do with this guy? Do you give him more isosorbide mononitrate, but this time in the evening? Do you evaluate this guy for esophageal disease? Do you increase the metoprolol and add an evening dose of ranolazine? Do you order pulmonary function tests with bronchodilator response? Or do you refer him to the sleep center for a sleep test? Well, I gotta figure out back at all that what they actually want me to do. So he refused surgery and wanted medicine. During the day, he gets that chest pain when he's exerting himself. But in the evening, he just gets it. It also said he takes all of his meds in the morning. Well, it also noted, now here's a hint, I think. It also says the patient is obese with a large neck circumference and a BMI of 34. It kind of screams for sleep apnea, doesn't it? So let's see. As much as I would like to give him an evening dose of a nitrate, I'm going to send him to the sleep center. Yeah. Seems like nocturnal angina, when he's got chest pain at night, is very closely associated with sleep apnea, especially in this guy's case. It is interesting because what happens when you have sleep apnea is your oxygen saturations go down. And if you have very little reserve in your heart thinks it's being suffocated. That hurts. So, chest pain at night, sleep apnea. 70-year-old lady comes to the office for a follow-up for shortness of breath. Over the last year, it's been getting worse. Now she can walk 2 blocks very slowly. Doesn't have chest pain, not lightheaded. She was seen at an urgent care facility a month ago. She's got crackles in the bases. She's got a little bit of swelling in the feet. She was given a diuretic. She felt better. And then told to come to see you, or me. She has high blood pressure and takes amlodipine and losartan for that high blood pressure. Never had a stroke, never had a heart attack, never smoked, doesn't drink. Blood pressure is reasonably well controlled. She is not overweight. When you listen to her heart sounds give it an S4. Lung sounds are normal, no swelling in the feet. EKG shows left ventricular hypertrophy. Blood work is fine. Her pulmonary artery systolic pressure is 50. Oh, God. Which of the following is most likely to improve the quality of life in this patient? Do you give her a beta blocker? Do you do exercise training? Do you give her a long-acting nitrate therapy? A low-carbohydrate, high-protein diet? Or phosphodiesterase 5 inhibitor therapy? Well, what she's got is group 2 pulmonary hypertension. So she's got pulmonary hypertension. That is because she's got left ventricular hypertrophy, or we're going to call this diastolic heart failure. Now, diastolic heart failure is very difficult to treat. But there's really not much you can do for the pulmonary arteries unless you fix the heart. Which is difficult to do. It's tough because you don't really do anything for this lady. You can't give her beta blocker because it doesn't work in heart failure. Her diastolic heart failure. I don't know why you give her a nitrate. She's not obese, so she doesn't need to mess with her diet. Also, calling it a low carbohydrate, high protein diet is silly. And then phosphodiesterase 5 inhibitor therapy. I mean, she doesn't have anything intrinsically wrong with her pulmonary arteries. It's because of her heart. Gosh. I guess the answer is exercise training, right? She has a diuretic. That's fine. She's not obese. She's trying to not be sedentary, but she can't really help it. She doesn't have diabetes. So what do? I guess you exercise her. Let's see. Yeah. Too bad. It's yeah, beta blockers are beneficial in heart failure with a reduced ejection fraction or systolic heart failure. So this is when the heart can't squeeze. What she's got is her heart really can't relax. Exercise it is. Like a 71-year-old guy. That's my dad's age. He's got chest pain in the ED. 2 days of mid-sternal chest pain and left shoulder pain. Fatigue, occasional sweating. Doesn't sound good. He sleeps on his right side because sleeping on his back hurts too much. He has known coronary artery disease, and he had a bypass graft placed 4 weeks ago. Post-op course complicated by atrial fibrillation and a post-operative fever. He has a temperature of 100.8. Blood pressure, pulse fine. He's saturating very well on room air. His cardiac and pulmonary examinations are normal. He has a well-healing sternotomy site with a little bit of redness, but it doesn't hurt when you push on it. He's got a left bundle branch block on EKG, but that was present on his EKG a few weeks ago, so not new. Chest x-ray has cardiomegaly and sternotomy wires with a small left-sided pleural effusion. So what does he have? Does he have mediastinitis? Does he have pericarditis? Does he have coronary graft occlusion, hospital-acquired pneumonia, or a blood clot in his lungs? Well, they didn't mention what meds he's on. He has a little bit of a temperature, but this sounds very cardiac-y and not what? What am I trying to say? Not bacterially, I guess. I don't think he has pneumonia. Now he's got an old left bundle branch block, so we would have seen something odd if the coronary arteries or the grafts were occluded. I don't think he has mediastinitis. I think he would be sicker if he did. But here's the thing. If he had pericarditis, it should show up on the EKG, but maybe not. Now, pericarditis usually gets better if you lean forward, and he's not sleeping on his back. So maybe that's what they're getting at. Yeah. So why does this guy have pericarditis? Let's see. It says the patient's clinical presentation is consistent with post-pericardiotomy syndrome, or PCIS, because he had that recent procedure done, coronary artery bypass graft. If you go horsing around in there, stuff's gonna hurt. That's what he's got. Looks like pericarditis. How do you treat it? Let's see. Advil or steroids. It also says prophylactic colchicine after the surgery will decrease that incidence. That's good to know. We've got a 25-year-old guy here for a pre-employment physical exam. He has no known medical problems. He weighs 143 pounds and he's 6'3". Oof. There is a faint early diastolic murmur, heard best at the second right intercostal space. That sounds like aortic insufficiency. Physical exam findings in the extremities are shown in these pictures that I will try to describe to you. What am I looking at here? Looks like very long thumbs. What should you do next? Should you do an anti-nuclear antibody test? Should you do a chromosomal karyotype analysis? Should you do a homocysteine and methionine level? Should you do a skin biopsy? Or should you do a transthoracic echocardiogram? Well, what's first, I suppose? I mean, that's a good question. So, ANA, I don't think I need an ANA. Scan biopsy. No, I'm good. Let's look at the picture again. So, picture shows somebody whose thumbs can go, when you hold them like this, when you hold the thumbs like this, goes way past. So he's got a connective tissue disorder. I think the next thing you do is just an echo, just to see what this aortic insufficiency is, because that's not good. And you can always do the chromosomal karyotype analysis later if you want to. Yeah, it's an echo. And yeah, I just assuming this guy had Marfan syndrome. So that test is called a wrist and thumb. So if you look at my wrist and thumb, I can't put my thumb past my little finger. And he can. Apparently that's a test for Marfan's. And he's also very tall and very skinny, so there's that. Okay. So we've got a 77-year-old lady in the ER. She's got left hip pain. She fell at home. Her history includes the following: high blood pressure, high cholesterol. She's got arthritis in her knees. She had a heart attack a little more than a year ago, and she got a bare metal stent implanted. She takes Tylenol, aspirin, and simvastatin. She had previously been prescribed a beta blocker, but she stopped taking it a couple months ago because she got tired on it. At baseline, she's able to eat her own meals, dress herself, use the bathroom, no problem. And she can walk up half a flight of stairs, but she's got to stop because her knees hurts. No chest pain, no shortness of breath, no palpitations, and she's never smoked. She is on IV morphine in the hospital, and she appears comfortable, as many of us would. Her blood pressure's up, pulse is fine, saturating well in room air. My blood pressure would be up if I probably broke my hip. Physical examination shows an externally rotated and shortened left leg. Guess what? She broke her hip. No murmurs on the heart exam. EKG shows a normal sinus rhythm with Q waves in the inferior leads. To me, that suggests she had a right coronary artery occlusion. X-ray of the hip, pelvis. Yep, she broke it. Her echo 6 months ago showed nothing surprising. Which of the following is the most appropriate next step in management of this patient? Now, it says, do you get a stress test? Pharmacologic stress test, because obviously she can't walk. Do you go right to surgical repair of the hip fracture? Do you repeat the echocardiogram? Do you start her on an ACE inhibitor because her blood pressure is a little high? Do you start her on a beta blocker? The woman broke her hip. In older people, and anybody really, a broken hip can actually kill you. The correct answer here is fix the hip. Yeah. Non-invasive cardiac evaluation, like a stress test or an echo, is not indicated in most asymptomatic patients undergoing non-cardiac surgery. So usually we want people to be able to walk up a flight of stairs at baseline without, getting short of breath or winded or something like that. No, we all get a little bit short of breath if we walk up a couple of flights of stairs. That's normal. But this woman got up a half flight perfectly, but then had to stop because her knees hurt. Doesn't count. She was fine. Also, a broken hip can kill you. So there's that too. All right. Let's do one more. I've got a 77-year-old guy. He passed out twice, so he came to the ED. First time it happened, he was reading a magazine after he ate a ton of food for dinner. And the second time it happened was today, in the bathroom after he peed. He felt lightheaded and nauseated. Had to sit down on the toilet before he lost consciousness, briefly. Never happened to him before. But he has experienced some lightheadedness during brisk uphill walking. Over the last couple of days, he had some abdominal cramps, a little bit of diarrhea. Not much, though. He was diagnosed with aortic stenosis a year ago. He refused to see a cardiologist. And in the ER, he says he feels weak, but okay. His blood pressure is fine. His jugular venous pressure is 10. There is a harsh 4 out of 6 systolic mid-peaking murmur at the base that radiates to both carotids. This is aortic stenosis. The second heart sound is soft, and the carotid upstrokes are delayed after the first heart sounds. His lungs are clear, and there's no swelling. I am now looking at his EKG. V1 looks pretty funky, not gonna lie. What's more, he's got, looks like, 3rd-degree heart block. Which of the following is the most likely cause of this patient's symptoms? Conduction system disease is the first answer. And right after I say he's got 3rd-degree heart block, that makes a lot of sense, but let's look at the other answers just to see if we can get persuaded otherwise. Left main coronary artery stenosis, severe narrowing of the aortic valve, vasovagal syncope, volume depletion. Guy's got 3rd-degree heart block on EKG. He's probably got at least close to severe AS, but that's not what's causing this. He just passes out randomly. He's got 3rd-degree heart block. Yeah, he's got 3rd-degree heart block. Explanation. The patient's syncope is most likely due to complete heart block, also known as 3rd-degree heart block. He does have severe aortic stenosis with the soft S2 and the very harsh murmur. But if this was aortic stenosis causing all this, he would pass out when he exercises. He gets a little lightheaded when he walks up the stairs, but read a magazine after dinner, nah. Using the bathroom, nah. Yeah. Sorry. All right. I'm going to call it here. Thank you for watching. And thank you, PJ, for the attention. I have been consuming his content for a long time. So, still pretty cool. But for now, I'm tired. And I hope you are too. Be well.